Hi, I want to talk to you about gastroesophageal reflux disease. Okay, someone says, I have problem. Then you say, oh, bunny mouth? Oh, yeah. Chest pain? Yeah. Okay, let's go through it. Gastroesophageal reflux disease could either be non-erosive or erosive, but that determination could not be made until endoscopy is done. It means that there is reflux of gastric content into the esophagus, and there are extra-esophageal symptoms, which are chronic cough, nausea, vomiting, bronchospasm, and of course, it exacerbates asthmatic attack. You become concerned because you start getting some warning signs when something serious is going on. And those are when the patient starts having weight loss or becomes anemic, bleeding, choking, or difficulty swallowing, dysphagia. Aspiration pneumonitis is very common and recurrent pneumonia as well. And with time, there's bronchiectasis from lung fibrosis. Conditions that could predispose to this are obesity, pregnancy, autoimmune conditions cause Scleroderma, and lower esophageal sphincter dysfunction. There is a condition called Globus hystericus. That is feeling of a lump in the throat that does not interfere with swallowing. The reason why that is brought out here is that that is what some people will actually have, and they will think they have gastroesophageal reflux disease. So they just feel that something is along their throat, but it's not burning them more than that feeling. That could be caused by gastroesophageal reflux disease on its own, but it has a different diagnosis because by the time endoscopy is done, there's nothing showing anything there. It could be as a result of anxiety or just a somatoform disorder, or maybe as a result of cricopharyngeal spasm. And of course, all inflammatory processes generally could lead to that. So when you do all investigations here, you get nothing. In fact, when you take the appropriate history and you know it is global hystericus, don't even waste money on any investigation. What are the symptoms here? It could be mild. When it is mild, it is not affecting any activities at all. You eat, you go about your normal duty, there's no problem. You sleep, you wake up, and then no night symptoms, no cough. No, for those who are asthmatic, it's no worsening the situation for them. That is mine. Could be moderate and then progress to severe when there's heartburn, water brush, cough sets in, recurrent asthmatic attacks, particularly to those who are diagnosed with asthma before. The larynx is inflamed, laryngitis, oropharyngeal or ulceration anywhere, dental erosions, dental caries, and of course chest pain that will give you concern because you need to rule out other causes of chest pain. So you have to rule out myocardial infarction and aortic dissection and the likes. The symptoms could be worsened by increased intra-abdominal pressure, and that could be as a result of cough, heavy meal, pregnancy, constipation, or delayed gastric emptying. So when intra-abdominal pressure is increased, it pushes the content in the stomach up, and then the reflux happens, particularly when there's lower esophageal sphincter dysfunction. How about alcohol, tricyclic antidepressants, and previous surgery? The treatment here is, first of all, non-pharmaceutical. You do everything to help this patient and help yourself if you are the affected individual to decrease weight. I told you the other time, some situation that could predispose to this is obesity, very high BMI. So get off the couch, walk around, exercise, try to lose that weight. Diet control, reduce coffee or no, chocolate, citrus juice, fatty meals, meds, tight clothing. Avoid spicy foods. No eating within 3 hours of going to bed. E.g., if you want to sleep at 9 p.m., then don't eat after 6 p.m. Why? When you lay down with heavy meal along the gastrointestinal tract, there's more possibility of you having reflux. Raise the head of your bed, add more pillows this time. If you have been smoking before, please, this is the appropriate time for you to quit. You can't be eating and lay down. You are not the type of human being, if you've been diagnosed with gastroesophageal reflux disease, you lay on your bed and you are chewing and drinking. No, please. How about pharmacological interventions? There's what we call proton pump inhibitors. You can choose any of them: omeprazole, pantoprazole, esomeprazole, and the list goes on. H2 receptor blockers like cimetidine, famotidine, ranitidine, isatidine. Just choose one of them. Then antacids. The proton pump inhibitors and H2 receptor blockers will prevent further acid production in the stomach. Here's the deal. The acid in the stomach is meant for the stomach and its function there. The lining of the esophagus is not prepared for the acidic medium in the stomach. So when there is reflux, when the acid leaves the normal position in the stomach and goes up into the esophagus, where the lining is not prepared for it, then there'll be damages. Later on, we'll talk about Barrett's esophagus later. So the major job here is to decrease production of acid, neutralize the already produced acid. And one way to neutralize the already produced acid is using antacids. While proton pump inhibitors and H2 receptor blockers will decrease of blood product production of acids. So to neutralize, you can use the Vol Plus that contains aluminum and magnesium hydroxide with simethicone, and 30 minutes after meals as may be required. You use Jelly Z, that one has aluminum and magnesium with simethicone also, but in a tablet form. Then you chew 2 tablets or 4 as may be required. There's a liquid form of it also, use 10 to 20 mils. Some will even treat H. pylori as well, because sometimes the presentation is like that of peptic ulcer disease. So just to save your time and have peace of mind, some will just treat H. pylori as well. And some are even implicating H. pylori in all these ages. But gastroesophageal reflux disease, we have to do more about lower esophageal sphincter dysfunction. If you have done both non-pharmaceutical and pharmaceutical ways of treating and you've not succeeded, if you are not winning, then sit back and rule out some other possible problems that could present the same way. Achalasia is the failure of smooth muscle to relax. Is that what we're dealing with here? Or eosinophilic esophagitis? Or improper use of medications? Go through the list of medications the patient is taking, check the dosage of these medications, because by the time you give your omeprazole or you give cimetidine, you give your Davoplos, you prescribe, or you've been dispensed with them and you are not taking them, then we may not get out of the problem. So, are you adhering to non-pharmacological measures? You losing weight? You watching the time you eat and the time you go to bed? About smoking? And just go over everything again and then see where we are failing, where we are not winning. Surgery is possible here when everything must have failed. But when exactly do we refer to these patients to surgeons? When there's possibility of hypertonia, that means the diaphragm is not supporting the strength that it's supposed to give in that region. When there's weakened lower esophageal sphincter, no matter your medication, it's not likely you win. When the endoscopy results indicates that this is the problem, and what's the problem? Erosive esophagitis, Barrett's esophagus, or intolerable symptoms by the patient, and everything you've done, they've all failed. Then the next thing is to let the surgeons have a look. Lower esophagus is a smooth muscle, so it's beyond our own self-will. We can't control it. It's not voluntarily controlled. That is why gastroesophageal reflux disease is still persistent. We can monitor the pH for 24 hours, and that is the most sensitive test here because the acidic medium in the stomach is low pH. So when you monitor that pH for 24 hours, you'll be able to determine whether truly the content is coming from the stomach and is acidic, because the lining of the esophagus is not prepared for that toxic environment. What is Barrett's esophagus? This is a condition in which the normal stratified squamous epithelium in the esophagus is replaced with abnormal simple columnar epithelium with goblet cells. Those ones are meant for the stomach and the intestine. Then that will lead to possible carcinoma called adenocarcinoma. So when that epithelial lining has been replaced by those ones meant to be in the stomach and the intestine, then we have prepared that region for trouble. So there's likely going to be cancer of the esophagus called adenocarcinoma because the squamous epithelial lining has been replaced by the columnar epithelial lining with goblet cells from the stomach and intestine. So when oxygen saturation is good and suddenly drops, check for the possibility of aspiration, because I brought that out because people with gastroesophageal reflux disease often do come down with aspiration. So this patient, perhaps you've not even made the diagnosis or it's not on the chart anywhere, and the patient is under your care, the O2 side is good, but suddenly drops. And this is not somebody taking opioid or anything. Please check for aspiration. but it's likely the individual will be coughing as well and increase in respiratory rate. The long-time use of proton pump inhibitor will increase the chances of bone fracture. Well, in life, there will always be merits and demerits. So, is this patient getting out of gastroesophageal reflux disease with proton pump inhibitor? Yes. Okay. Chances of bone fracture? Yes. Okay. There are stuff we can do will help. Okay. Give vitamin D, give bisphosphonates, give everything that could help this patient, including calcium, maybe. You can also use prokinetics. When you use prokinetics, it means you are not letting the gastric content move down fast. When they move down fast enough, when you increase peristalsis, the possibility of stasis and backflow, which is reflux to esophagus, is decreased. And under that circumstances, you are comfortable with either metoclopramide, erythromycins, domperidone, or betanicol. What are the complications here? Burning mouth syndrome. That could lead painful scalding or tingling in the mouth. Like I said, an acid is an acid, and when it leaves, hydrochloric acid in the stomach leaves that region, comes to esophagus and up to the mouth, then you're going to feel it. Ulcer along the entire tract. Stricture after healing and fibrosis sets in, then that place is going to narrow. And the reason why there will be dysphagia, because dysphagia here will be that it will first of all start with solid substances, bolus, then later liquid when it gets worsened. Esophageal carcinoma, because there's Barrett's esophagus, the replacement of epithelial lining, squamous replaced with columnar, with goblet cells, and so on and so forth. Adenocarcinoma are setting here. Upper gastrointestinal bleeding, probably hematemesis, but when it is low enough and it's just going down, malignant stool will show. Like I've said, Barrett's esophagus is outer cell lining of the mucosa of the lower portion of the esophagus. So orinophagia is painful swallowing because there is ulceration along the tract. In conclusion, gastroesophageal reflux disease should not lead to complications if all precautions are taken. So non-pharmacological measures will suffice in most patients if strictly adhered to. But if not, you are free to add some of those pharmacological measures. Okay, please subscribe to my channel. I will be able to let you have all the videos that will be produced on timely basis if you subscribe. And I'm actually wishing all diagnosed patients with gastroesophageal reflux disease well. Thank you.